let's shift to something that's simple. Okay, not those difficult, very challenging work that you have been doing. I couldn't imagine myself working on like vaccine development, talking about lifetime commitments. I can't do it. Okay, I like something simple. Now, well, I'm going to cover basically 3 areas. One is the technology that we develop for use in the point of care assays. And of course, one area that we're working on is the influenza detection, and also for detection of resistance to neuraminidase inhibitors. And finally, I'm going to just briefly cover areas that we are working on, and that's the assays for detection of superbugs, and that's it's also a very important topic, probably second only to influenza. Now, we are interested in point of care test. So design attributes for a good point of care test is that it ought to be suitable for use in physician's office, because that's where people go to when people got sick, initially at least. And it has to be easy to use. Believe it or not, the FDA actually has a definition for easy to use, and that is somebody who has a 7th grade education will be able to perform the test without any training, but just by reading the instruction. And that's not that easy, so easy is not easy. Of course, it has to have a superb performance characteristics, and that is rapid and sensitive and specific, and also qualitative and quantitative. And very important, these assays cannot be expensive. So you just cannot put a PCR machine in a physician's office. That would be too expensive. The assay technology that we develop, we call a homogeneous biochemiluminescent assay. It's based on the firefly luciferase and luciferin reaction. So the homogeneous meaning the assay will not require washing, just a wash-free assay that completely substantially simplify the assay. It's based, as I say, it's based on firefly biochemiluminescence, and that's probably one of the most efficient light production system in nature. So it's a platform technology. We can use that for development of a number of assays, and it's suitable for use in point of care settings. And we have used this assay now to develop a bunch of assays, mainly the enzyme assays. For some reason, it doesn't work very well. So all these assays are now going through clinical trial. And in fact, the first 2 assays, and the Q-Flu combo assays and Q-Flu DS assays, we have done clinical studies, and these 2 assays have been CE marked. And of course, we are working on the superbug assays. And we are also working on the immunoassays as these assays are moving into clinical phase. Now, so today I'm just going to cover 2 assays, the Q-Flu combo assay and then the superbug assay. The current method for detection of neuraminidase inhibition or inhibitor susceptibility are: one is cell culture-based assays, inhibition assay, which is of course very complicated to perform. And molecular assays, you can also use that, and by sequencing the gene to identify mutation. You can also use nucleic acid amplification assays like PCR to detect mutations. But you have to know the mutation first. And more recently and probably more commonly used assays now are biochemical assays that's neuraminidase inhibition assays to estimate IC50s. But all these assays are too complicated to be used in point-of-care settings. Now, the IC50 assay, as you know, involves probably at least 8 reactions, probably 12 some people. So using 8 to 12 reactions with increasing amount of neuraminidase inhibitors. And so what you get is this a curve, and you use this curve to estimate IC50. But we try to simplify this assay. We say, well, probably you don't need 8 or 12 assays. We probably just need 2, and one with drug and one without drugs, and 2 assays. Rather than use this a curve, and then we can use the ratio. So that's we call it R factor. So this is the assay we're going to mention. It's a Q4 combo assay. These 2 tubes are identical, except that there's an extra bit in reaction 2, and the extra bit is Tamiflu, or we can use any other neuraminidase inhibitor. So what we come up with is the R factor, which is the A signal phase 2 that reagent 2 divided by reagent 1 times 10, just to make it look a little bit bigger. The chemical reaction or biochemical reaction is as such, and we use this chemical, which is a conjugate between luciferin and neuraminidase acid. It's a modified neuraminidase acid. It's a methylated at 4 and 7th position to make specific for influenza viral neuraminidase. In the presence of neuraminidase, the substrate is cleaved to release luciferin, which becomes a substrate of luciferase, and it's oxidized by luciferase to produce detectable light signal. This is the assay, how it works. Now, it generated a stable, long-lasting light signal. So at least only 60 minutes. So, but it could last it for days. Say if we started this morning, this reaction, you will still be able to detect maybe half of the signal by the time you finish this conference 3 days later. So it lasted for days. It's linear because you want to detect the drug resistance. It has to be a quantitative assay. So it depends on what luminometer that you use. The linear range from 2.5 log to about 4 to 5 logs. You can, of course, use that as an inhibition assay. In this case, you just add increasing amount of inhibitors, and you will see the decrease of signal. This is very similar to the IC50 assay now. But now we formulate this assay as a point-of-care test. So we have 2 test tubes, and so all you need to do is to take the sample and add the sample into the test tube and let it incubate for about 15 minutes at room temperature and put it into a simple luminometer. The whole process takes about 16 to 17 minutes after you collected the sample. Now, to show whether this 2 reaction format would work, to estimate the susceptibility, in this study we mixed a susceptible virus with a resistant virus. And so on the left is you have 100% susceptible virus, and on the right you have 100% resistant virus. So as you can see, there's a nice correlation between the proportion of drug resistance virus and the R factor. This is a 2 virus that we used in the previous study, and 2 different concentrations The one is resistant, the other is susceptible. As you can see, based on the R factor, they can be easily separated. So this is we tested about 200 isolates. About 100 of them were 2008-09 H1N1 influenza virus from the United States. If you recall, that year, almost all the isolates isolated in the US were resistant to Tamiflu. So all the other viruses either isolated a previous year or the same year is H3N2 or type B virus. So as you can see, then the assay R factor can very accurately detect drug resistance virus. Now, so these two assays have been CE marked. We have a lot more data on this. So we got CE marked for both the drug resistance assay and the Q-flow diagnostic assay. Now, I'm going to shift your attention to Superbug, which is an assay very similar to the Q-flow combo assay. So this has been in the headline for a couple of months now that probably hundreds of people in UCLA hospital were infected with the, exposed or infected with the superbugs. So what are superbugs? And superbugs are bacterial species that produce carbapenemase and are hence resistant to carbapenems. Okay, carbapenem is an antibiotic that are used as a last resort antibiotic. In other words, this will be the last thing that you use. So bacterial species that are resistant to carbapenems are often resistant to other antibiotics as well. So essentially, if you are infected with this virus, this superbug and get into your bloodstream, there will be no antibiotics to save you. So resistance to carbapenems are enabled by carbapenemase, which is actually a type of beta-lactamase that can degrade carbapenems. It's encoded by a plasmid. It's a mobile plasmid, which can be easily transmitted between different species. That's why it's a huge public health issue. If somebody's superbug gets into the environment, and that potentially can be transmitted to other bacteria and then can get in to other people. So it's a huge public health issue. Now the infection rate in enterobacterial species in US in 2001 is about 1%, so that's why it really didn't attract much attention. But after 10 years, so the infection rate is 4.2% now. It's about 4.2% of us will carry bacterial species that's resistant to carbapenem. So given another 10 years, so this will be probably more than 10%, and that's why now it becomes a hot topic. Interesting that we developed 2 years ago, we developed a very similar assay to the superbug assay, which we call a QCPA assay. That similar assay is a QAR assay. It's for detection of beta-lactamase inhibitor. Resistance is very similar to Q-flow combo assay. You also use two reagent format. You also use R factor, and it detects beta-lactamase, the QAR assay, and you detect beta-lactamase inhibitor resistance. Now, the reason we didn't pick superbug at that time, 2 years ago, was because we didn't think there was a market. Being in the commercial sector, we have to consider commercial viability. But it turned out that now every hospital in the U.S. is scrambling for easy to use superbug assay because they want to screen all the patients gets into the hospital. So, and then if they find superbug activity, then we'll isolate this patient. So that's why there's a need for these assays, and that's also become our high priority effort. Now, of course, we don't have superbugs in our lab, but we can clone, we can make superbugs essentially. We can clone that recombinant protein and express it in E. coli that make it essentially superbugs. So we clone 4, but essentially 3 classes of beta-lactamase, and 3 of them are considered candidates or are carbapenemase. So that the last one is probably you know that it's called neutral metal beta-lactamase. So this is resistant to just about all antibiotics. So if you look at the R factor, so our assay, QCPO assay, can identify all these 3 species of beta-lactamase. And this QAR assay is for detection of beta-lactamase inhibitors. So it didn't pick up this particular species of beta-lactamase. Now, this is a small kind of what we call beta clinical test testing. So that's, you know, we want to test the assay before we actually perform the clinical study. And we test this cohort of patient sample from 23 patients in a hospital in Shanghai. So use the QAR assay. Now, of these 23 sample, 13 carried beta-lactamase activity. So of the 13, and 5 were resistant to beta-lactamase inhibitors. You know, these are actually precursors of carbapenemase. So if you extrapolate into the entire population in China, and so about half of the population in China carry actually a bacterial species that's resistant to beta-lactam antibiotics, essentially, and it has a beta-lactamase. And about a quarter of them, maybe 30% of them have a beta-lactamase that's resistant to beta-lactamase inhibitors. And so we are now working on trying to see, you know, increase the sample size and see how many of them are actually superbugs. But I will not be surprised, a significant portion of them are actually superbugs. So it's actually, although the sample size is very, very small, it's actually an indication of how serious this problem is. It's probably as advertised. So to summarize, we developed a technology called homogeneous biochemiluminescence assays. They are rapid, easy to use, and sensitive and quantitative. And we use the assay in the 2A reaction format, and that's that's significantly simplified drug resistance detection and could be used for in point-of-care settings. And since many enzyme targets are actually also drug targets, so we can use this assay now to develop drug resistance assay to lots of drugs. And money, okay, it takes money to get you somewhere. So of course, most of money comes from NIH grant. We also got some money from USDA and State of Maryland. And believe it or not, it's Montgomery County is a county that's in the state of Maryland. And of course from CDC and BARDA now. Collaborators in CDC, Johns Hopkins, and Northwestern, which is not too far from here, University of Maryland, Alabama, and Hofstra, and NC State Public Health Lab, and then also BD. Thank you.